Good evening. I welcome all to this webinar on lung fibrosis, progressive pulmonary fibrosis, and the use of antifibrotics. ILD is one area where there has been rapid strides in last few years, and our concepts, especially with regard to management, have changed rapidly with the development of new drugs. Earlier, we had new drugs like antifibrotics for idiopathic pulmonary fibrosis. Subsequently, it has been realized that there are other entities which are also fibrotic, non IPF fibrotic interstitial lung diseases, where also there is a scope of using these drugs. And a few recent studies have documented that drugs which we were using for IPF are also useful in certain patients with other fibrosing ILDs. So things are changing rapidly, and so that improves the outlook for these patients, good for these patients. So that is the subject of our discussion today. And as per the format, I'll start with a brief presentation about what are ILDs, specifically what are the fibrosing ILDs, and what proportion of these would progress. What is this phenotype called progressive fibrosing ILD, or what is now called after the recent guidelines as progressive pulmonary fibrosis. And then we'll open up to the panel for discussion on different aspects of progressive pulmonary fibrosis, including their management, and then audience is free to come in and ask questions. So we will start with the presentation first. So we are going to discuss about a subset of ILDs which are clubbed under the heading fibrosing ILDs. IPF or idiopathic pulmonary fibrosis is the prototype fibrosing ILD, but there are other ILDs which behave like IPF, and these have been recognized more recently. So now these are clubbed under non-IPF fibrosing ILDs, and among them a subset progresses. So these are now recognized as progressive pulmonary fibrosing diseases. Now, interstitial lung diseases, or also called diffuse parenchymal lung diseases, these number more than 200. There are different classifications, but one of the commonest ones is shown here, where our primary objective in a diagnostic workup is to define whether this is an idiopathic pulmonary fibrosis or a non-idiopathic pulmonary fibrosis, ILD. So that is the first step in the diagnostic workup. There are idiopathic interstitial pneumonias, of which IPF is the commonest. Then there are autoimmune disease-related ILDs, hypersensitivity pneumonitis, sarcoidosis, and so on. This distinction between IPF and non-IPF is important because the management of IPF is entirely different, more so after the introduction of antifibrotics and the recognition that corticosteroids have no role in the management of IPF. All other ILDs, non-IPF ILDs, are treated with corticosteroids and other immunosuppressants with variable degree of success. Now, the ILDs, their natural history is extremely variable. There are some ILDs which can show improvement with treatment, notably diseases like sarcoidosis or hypersensitivity pneumonitis. Then the other end of the spectrum are diseases which have a rapid decline downwards, typically these like IPF. Then there are other ILDs which progress slowly, decline slowly in their natural history. There are yet other group of ILDs which remain stable for a long term before the clinical presentation or there is some change in their manifestation. These diseases have periods where there are sudden declines called acute exacerbations, which result in a worsening of the further natural history. So these can punctuate the natural history. So as we can see, the spectrum of ILD is extremely wide. Broadly, we can discuss the pathogenesis under the heads inflammation followed by fibrosis. That is a general scheme of development of ILDs. But today our focus is not on pathogenesis. This I am mentioning only to point out that the treatment that we have for ILDs is based on recognition of inflammation and fibrosis. So for disease where inflammation is dominant, and that includes most of the non-IPF ILDs, steroids and immunosuppressants are the drugs which are used. Antifibrotics are reserved at present for idiopathic pulmonary fibrosis, but recent years we have gained some information and there are publications which show that these diseases may have a role in non-IPF ILDs also. So that is why this webinar is being organized. Now, among the ILDs, there are certain ILDs which have a greater component of fibrosis. Non-specific interstitial pneumonitis, some of the autoimmune ILDs, hypersensitive pneumonitis, sarcoidosis, which means the ratio of inflammation and fibrosis favors fibrosis. And in these diseases, which are fibrosing ILDs, there are about 20 to 30% of patients who will show a progress. Now, these are the patients who typically behave like idiopathic pulmonary fibrosis. So now this issue is being discussed, that subset of non-IPF fibrosing ILDs which progress, which are now labeled as progressive fibrosing ILDs or more recently progressive pulmonary fibrosis, should these be managed on the lines of idiopathic pulmonary fibrosis. So about a quarter of fibrosing ILDs will behave, and that holds true across the spectrum: hypersensitive pneumonitis, sarcoidosis, connective tissue related ILDs. So 25-30% patients we can expect to progress, and these progress quite rapidly. So from the initial symptoms of ILD, by the time a diagnosis is established, about a year is lost. Then as these diseases progress and become fibrosing ILDs, another year is lost, and by the time the physician detects that these are progressive pulmonary fibrosis, further time is lost, and these patients have a poorer outcomes. Pathogenetically, they have changes in their pathogenesis which resemble the pathogenesis of idiopathic pulmonary fibrosis, in that there is a self-sustaining lung fibrosis. So I am not going into details, but there is an activation of fibroblasts and active fibrogenesis and laying down of extracellular matrix is there, and that is the reason why these fibrosing ILDs progress and go downhill. So this new phenotype has been recognized, labeled as progressive fibrosing ILD. Here the natural history is characterized in a patient who has a non-IPF fibrosing ILD, showing a decline in lung function, worsening of symptoms and health-related quality of life, greater impairment of vital capacity and diffusion capacity, CT scan showing signs such of increasing fibrosis. So these diseases have a poorer outcome compared to those diseases which do not progress. If we compare the progression in fibrosing ILDs, which are progressive, then these quite resemble idiopathic pulmonary fibrosis in terms of their outcomes. So similar worsening, similar decline of lung function, decreased quality of life, and early mortality. So that is why now focus is shifting to a different kind of treatment for these progressive fibrosing ILDs. The outcomes have been compared in non-IPF fibrosing ILDs. Those patients, about 25-30%, as I mentioned earlier, which progress, they have a poorer outcome, a mortality which resembles idiopathic pulmonary fibrosis. So what we can say is that progressive fibrosing ILDs, these resemble IPF. So that is why the treatment options are also being changed for non-IPF progressive pulmonary fibrosis. Who will progress among fibrosing ILD is very difficult to say, but it has been seen that patients who have hypertension pneumonitis fibrosing ILD, RA-ILD, especially those with poor lung function, they are at a greater risk to progress. Among connective tissue disease ILDs, certain features like a larger area involvement in CT, progressive decline in FVC, among scleroderma associated ILD, a positive anti-SL70. So these are some of the risk factors which predict that a particular patient may have a more progressive fibrosing ILD. So the first study which changed the management of these patients is the inbuilt study. That was a study with 600 plus patients with nintedanib, and where they selected patients who, after 24 months period of observation, treatment with steroids and immunosuppressants, showed a decline in lung function. So they had their criteria, which I am not again going into detail. And this led to the formulation of guidelines for progressive pulmonary fibrosis. So this was published in 2022 May, where they recognized progressive pulmonary fibrosis as a distinct phenotype of non-fibrosing ILDs. And this was defined on the basis of worsening of respiratory symptoms, physiological evidence of disease progression, where they defined progression in terms of a decline in absolute value of FVC more than 5% within 1 year of follow-up. In inbuilt study, that duration was 2 years. Similarly, a decline in DLC of more than 10% predicted value within 1 year of follow-up. So 2 out of these features, symptoms, physiological decline, and third, radiological evidence of disease progression, where increased extent or severity of traction bronchiectasis or bronchiectasis, new ground glass opacity with traction bronchiectasis, new fine reticulation, increased extent of coarseness of reticular abnormality, increased honeycombing, increased volume loss. So these were radiological evidences of progression of fibrosis. So if there are 2 out of these in a patient who has a non-fibrosing ILD, then the patient can be said to have a progressive pulmonary fibrosis. And for this phenotype, the outcome, which was as dismal as IPF, has changed after the inbuilt study, where nintedanib was tried, and now FDA has approved the use of nintedanib for management of progressive pulmonary fibrosis of non-IPF ILD. So this is one example which I am showing. This patient had NSIP. The upper panel shows a CT scan of May 2019, and 1 year later in June 2021. So we can see from the physiological data, the 6-minute walk test, the degree of desaturation on exercise, these decline. There was a fall in FVC from 67% to 49%, a fall in DLCO from 42 to 33%. So this patient met the physiological criteria of decline. Plus, there was radiological evidence of increased honeycombing and more coarse reticulation. So this patient was defined as having a progressive pulmonary fibrosis and was started on nintedanib. So the use of antifibrotics like nintedanib has therefore widened after the success of the inbuilt study. So we have greater application of antifibrotics not only in IPF but also in non-IPF ILDs, which are progressive. So to summarize, the ILD is a large heterogeneous group of parenchymal lung disease with more than 200 entities. About 20 to 30% of patients who are diagnosed with non-IPF ILDs will develop a progressive fibrosing phenotype called progressive fibrosing ILD, or more recently, progressive pulmonary fibrosis. Clinical recognition of this phenotype is based on any 2 of the 3: duration of symptoms, lung function decline, and radiological appearance of signs of increasing fibrosis. These diseases have a poorer outcome. Their outcomes are similar to those in IPF who are not treated, and they have a faster decline and a higher risk of mortality. So poorer prognosis as compared to those fibrosing ILD which do not progress. So it is very important that we recognize this phenotype of progression early and start appropriate management. And the good thing for these patients is that antifibrotics, nintedanib, have been approved by FDA for use in progressive pulmonary fibrosis, and in few months we expect that pirfenidone will also be approved. So now we'll be discussing the management, the outcomes, how we recognize and how we clinically handle these patients in our discussion. Thank you. Before we start our discussion on this topic, let me introduce my esteemed panel. We have with us today Dr. Arjun, very well-known pulmonologist from Kerala. Then Dr. Shweta Bansal she's from Delhi. Dr. Neel, Thakkar, Vadodara. Then we have got two transplant pulmonologists. Dr. Apar, Jindal is there, and then Dr. Kapil. He is actually right now in the transplant ICU because there's a patient. So he may be coming in and going, but I hope that we'll have the benefit of his experience and wisdom also. So a great panel to start with, a hot topic which is evolving. We have some evidence, we have some practices going on which may not have scientific evidence today but may become the science of tomorrow. So an evolving area, and very important because pulmonologists see these patients very frequently, very often in advanced stage, and because there is a dearth of options available, there's always a question whether we can use the newer drugs or not. So let's hope that we can go into the depth and try to come to a consensus or at least provide some solutions to our audience. So while we are talking about progressive pulmonary fibrosis, discussion will have to start from idiopathic pulmonary fibrosis because that is the prototype, and the use of antifibrotics, the experience we got from IPF, and that is what is being extended to the progressive pulmonary fibrosis. We have come a long way in the management of idiopathic pulmonary fibrosis. There were guidelines in 2001 where steroids, NAC, and azathioprine, these were recommended as treatment, and that was the standard of care for 10 years. Then in 2011, it was realized there's no role for steroids and immunosuppressants. So these were withdrawn. So next 4 years was a vacuum as far as medical management of IPF was concerned, and lung transplantation was the only hope for these patients with advanced disease. Then newer drugs, antifibrotics, came in. There were studies which showed that these drugs, while they cannot reverse the process of fibrosis, at least they retarded. So that improved the outlook for these patients. So, Dr. Arjun, if I can come to you first. Antifibrotics, nintedanib and pirfenidone, there have been few studies when these were launched. So can you just enlighten us about these studies? What was the evidence on which their use was approved in IPF? The major studies for these two drugs in IPF.
Thank you very much, sir. Thank you for having me in this panel today for this wonderful discussion. So the question to me is how the antifibrotics in IPF and the evidence. So we have two drugs that are commonly used, pirfenidone and nintedanib. The pirfenidone was perhaps the first drug which was approved for use in IPF. And there are two major studies for the ASCENT trial and the Capacity 1 and 2 trials with pirfenidone, which showed that pirfenidone actually reduced the decline in lung function as evidenced by FVC, and this also reduced the progression of the disease. Very interestingly, the subgroup analysis of the capacity trials also showed that pirfenidone may have a mortality benefit with IPF as well. So there was initially a lot of confusion as when one should start IPF treatment with pirfenidone in IPF, and the patient is not responding whether you should stop the drug. But because of this evidence, it's better to start at any point in time because of the mortality advantage pirfenidone confers in patients with IPF. As far as nintedanib is concerned, the two major trials of the Tomorrow trial and the Impulses 1 and 2 studies, both of which again showed that it reduced the decline in FVC. And although the major side effect that was observed in that was diarrhea, it was not a serious adverse event needing stoppage of the drug. You just needed to reduce the dose and the patients could be continued on that. So these are the major trials, initial trials for these two drugs in the management of IPF.
Yeah, so thank you. So these were the trials which provide the basis for adding drugs into the armamentarium for IPF. Now, as Dr. Arjun has told us, these drugs slow down the decline in IPF. Now, how does it Dr. Bansal? Now, patients, they come with dyspnea, cough, poor quality of life. So what can we expect from antifibrotics as far as patient-centered outcomes are concerned? What benefits the patient will come in terms of the progress of disease and relief of symptoms with these drugs?
Sir, as there is evidence now that in progressive pulmonary fibrosis, these antifibrotics do have improvement, not improvement, but reduction
IPF. We'll start with IPF.
Okay. So in IPF, basically, it helps in the reduction in the decline in the FVC. So there is decline in the decrease in the decline of lung functions. So definitely there is decrease in the symptoms and improvement in the quality of life. And it does helps in decreasing the exacerbation rates, as well as the studies have shown that they help in reducing the mortality as well.
So these were the benefits. Most importantly, that because the disease gets slowed down, so it is expected that the patient is going to live longer and the complications will be less. So especially with internet, the exacerbations were reportedly be. So the patients may not get much relief in their symptoms which were there at the time of starting the treatment. The reason is that these drugs don't reverse the existing degree of from that point onwards, the decline and the progress of disease that can be slowed down. And as Dr. Arjun told us, the trials have shown very clearly that patients who, if they're not on these drugs, IPF, they would lose about 200 to 250 ml FVC per year. But when they're on antifibrotics, then the rate of decline is reduced by 50%. So they would lose about 90 to 100 ml per year.
But you really have to be patient because they do take a time, at least 3 to 6 months minimum for the response.
No, Dr. Thakkar, these drugs, once we started using them in real life, we often come across adverse effects, and sometimes one has to withdraw or reduce dose. So with both pirfenidone and nintedanib, these problems are there. So in your practice, once the patients are initiated on one of the two drugs, then how do you monitor these patients and how do you tackle the side effects as and when they arise? What are the adverse effects that you see and with their management that you do?
Thank you, sir, for the excellent discussion as well as this question. So, like you already, the initial discussion was there on pirfenidone and nintedanib both. So, whenever, suppose a patient, we have to decide that, okay, I'm going to start this patient on pirfenidone. Then initially, before starting the drug, we make sure that at least the patient's liver function test is done. It is normal before we start the drug. Normally, we tend to start with a dose of at least 40 milligram per kg. So for a patient, suppose we are going to start, say 800 milligram TDS, we are initially targeting. But we have to also see the patient's tolerability with these drugs as well as the symptoms. Suppose I've started a patient on pirfenidone and on the second or third day, patient has complaint of severe vomiting, abdominal pain. Number one, I'll be monitoring the symptoms. Number 2, if there is any specific photosensitivity with pirfenidone. Number 3, if any gastritis or vomiting, diarrhea. These are the side effects I would look for. For self-monitoring as well as for routine clinical follow-up, what we routinely check is the pulse oxygen, that is the pulse oximetry, as well as the 6-minute walk test. If there is, we make sure that we have serial readings right from the start when we start the drug. We've done a lung function test before starting and at 3 to 6 months on antifibrotics to monitor the rate of decline or improvement, what it is with the antifibrotics. With nintedanib, we would anticipate a side effect of diarrhea, which is very common. Secondly, if a patient is of ischemic heart disease or is on dual blood thinners, we would ensure that we have a proper coagulation profile, especially for patients on dual blood thinners, where there could be some, I've seen in patients where there have been some level of bleeding tendencies also, especially when on dual blood thinners or anticoagulation. So these are just some common effects which I would like to monitor in my routine practice on pirfenidone and nintedanib. Pulse oximetry and lung function test remain most important, along with clinical symptoms as well as radiology. Yes.
Thank you, Dr. Thakkar. So, Dr. Jindal, after antifibrotics have come in, when these were not there, and that high test which I mentioned, that no treatment, that was what we were offering, except the option of lung transplantation. So now that antifibrotics have been introduced, so naturally, if they are working, patients would be listed for transplantation later in their natural history than they were earlier. So how do you find this, that if they are responding to antifibrotics, then would they still be listed for lung transplantation? How that practice has changed after introduction of antifibrotics?
Excellent question towards me, sir. So let me just divide this question into 3 different parts. One is, as the antifibrotics has come in, does it affect the timing of listing for the patient? And I'll bring in one concept over here where I'd like to bring out the terminologies of referring a patient versus listing a patient. Secondly, has it affected the outcome of the patient getting transplanted or not? And thirdly, one of the effects which is closely associated with nintedanib and proven over there, still work is going on with pirfenidone, is reducing the number of exacerbations. How does that affect the culmination into a transplant? So when we say that whether or not the patient is to be listed for a transplant, that already means that the patient has gone beyond all medical help. So let's not use the term listing in a very casual and a very loose manner. From the perspective of a general pulmonology, and I'm a general pulmonologist first and a transplant pulmonologist later. So talking about a country doctor, let's talk only about referring the patient. So although probably nintedanib, pirfenidone, or a combination of the two, or any one of them alone, have delayed the onset of say progressive fibrosis, have slowed down the appearance of hypoxemic associations like pulmonary hypertension, the bone and muscle loss, the GI loss, and all those things. But still, the patient slowly is itching towards that. I mean, the word antifibrotic is a misnomer in itself. These do not cause antifibrosis. They're just slowing down the progression of the disease, but the patient is slowly moving towards it. So what I feel is appearance of any fibrotic disease, and this has been included into the guidelines as well. If you look at the candidacy selection guidelines from 2021 and right all the way from 2014, this word has been included, that any fibrotic illness in the lung, and I'll limit myself to that because we're not talking about other things over here, is an indication to start talking to the patient. The dialogue has to open right at that point of time, that yes, you may need at certain point of time in life. Now comes the second aspect of it, that the exacerbation aspect of it, what I'm talking about. So the use of nintedanib or the use of pirfenidone also in many cases has definitely reduced the number of exacerbations that these patients face. And that is one of the major endpoints from all the various data that we have. What this also means is, when we look at a normal transplant, when we look at the success ratios of a patient who is undergoing a transplant off of oxygen, be that 10 liters of oxygen versus somebody who's in an acute exacerbation with NIV support or HFNC support, the difference is a 90% success rate to a 95% success rate. which falls down to about 25 to 30% post-transplant survival. And I'm talking only about the immediate post-transplant survival. This is something that can be greatly affected by the use of these drugs. So the difference between the time period that the patient is diagnosed with the disease to the time that the patient is referred for a transplant to the time that the patient is actually listed by the transplant unit for the transplant is all the difference that these drugs have made. But the progression and the natural history of the disease still remains the same. So the patient needs the transplant. What it ultimately means is that the time to prepare for the transplant is more with the clinician as well as with the transplant team and the patient.
He's reaching that stage later, hopefully. So that is the expected benefit. So at least that takes the load of the transplantation services also.
Absolutely.
So thank you. And since these drugs have been used extensively and all of us have experience, so I would like to know from our panelists, like how often you need to reduce or stop one of the antifibrotics or switch to another one because of intolerance. Dr. Shweta?
Yes, sir. Most commonly with nintedanib, I have encountered diarrhea, very, very common. So that is a side effect for which I have to shift it to pirfenidone.
Almost 1/3 patients have intolerable diarrhea.
Yes, sir. But otherwise, no.
Well, reducing the dose help there, like from 150 to 100.
Yes, sir. Yes. Once I stopped the drug, yes. Sometimes in one of the patient I did that, and the patient tolerated well. But few others I had to shift to pirfenidone only.
It's a difficult question. A patient who is otherwise responding, and you don't want to lose a good drug.
Actually, yes, sir. But
maybe
patient
interval of a week or 2 weeks for them to respond. Add,
introducing
drug like lactobacillus or something like that.
Yes, so we can try that, but anyways, you will have to look for the severity, how much is the severity and the patient preference also. Because with pirfenidone, the major disadvantage is the pill burden. Though we now have 800 milligrams tablet, but still listening to that he has to take 800 milligrams, 2,400 milligrams a day. It's like the psychological thing for the patient. So I would prefer to start with nintedanib, but with pirfenidone, I have not encountered major side effects.
Dr. Arjun, ever had to stop pirfenidone or nintedanib or switch because of adverse effects?
My experience has been actually the opposite. I think it tells us.
Audio is disturbed. Administrator, please have a look at the audio. Please go on.
Yes, my experience, in fact, has been the other way around. Probably there might be some genetic variation in the people down south, I don't know. But diarrhea is very seldom seen in patients whom we start nintedanib. It's not my observation, but my colleagues as well. We have actually been using only the generic molecules that are available in the country, which came after COVID. But still, that's something which we rarely see. On the other hand, adverse effects, what we have observed are more with pirfenidone. Basically, because the moment you cross the 1,600 milligram, our people will not tolerate that. So we are unable to reach the optimal dose that is needed, and hence, because of intolerance, we have either to reduce the dose or think in terms of changing to nintedanib because of the lesser pill burden and probably a better safety profile amongst our population here.
Dr. Thakkar?
So can I?
Yes. I think Dr. Kapil wanted to say something. Yes.
Hi, Dr. Kapil, you are actually getting a priority because you might have to rush back.
No. So first of all, I would just like to apologize, to the audience and all of you, because of some unforeseen circumstance, I'm just going in and out. I just came in on this question and I completely agree with both, Dr. Shweta and Dr. Arjun. Actually, the gastrointestinal side effects of both pirfenidone and nintedanib is extremely crippling. In our practice, unfortunately, all the trials which have been done always mention that the dose should be 800 milligrams twice a day. We have just got that combination. I still remember back in the day, the pill burden was so high because the only tablet which was available was 200 milligrams. So, the patient had to take so many tablets. And at that, in my own experience, I say at least 40% of my patients would not tolerate it. And I'm talking about 2014, 2015, nintedanib hadn't made a huge splash over here. So we unfortunately were just restricted in reducing the dose of pirfenidone. And later on, when we tried switching these patients onto nintedanib, when they didn't tolerate pirfenidone, we also noticed that nintedanib also was extremely difficult because of loose motions. So I feel that theoretically, when we read skin manifestations and allergies and all, I think it's more of theory. But in our country, I feel gastrointestinal side effects is the number one crippling factor when we talk about antifibrotics.
Yeah, Dr. Thakkar, your take on this?
Definitely, sir. I completely agree. But what the other side from the patient's perspective, what we get? Suppose I reduce the patient's dose transiently. Patient has got a gastritis, diarrhea, or vomiting. Then the patients get used to that overdose. So irrespective, later on, suppose like you said, sir, 2 to 3 weeks, suppose we give a trial key, we reduce the dose. And then after that, whenever we try to increase the dose, number one, they will have that psychological prohibition.
Yeah, true.
Tolerating this dose. Number two, even when we explain that theoretically, an optimal dose, then over 2 to 3 months, the function of the drug will be acting more. That cumulative impact will be more if you take it in full dose. But that is the challenge we face when there is recurrent gastrointestinal symptoms. In most of the patients, because of the gastritis symptoms, we do prescribe some sort of an antacid, as well as we make sure that the food is taken with appropriate difference with the meals, so that patients do not have immediate GI side effects. But like you said, we have to do dose adjustments so that the patient tolerates the drug better, or then eventually change the drug. Definitely.
Yeah, that is a major limitation. In fact, with nintedanib especially, I've noticed that just like with ATT, elevation of transaminases is very common, and we apply the same strategy. If it's just up to 3 times without symptoms, we let the patient continue. So mere elevation of liver enzymes is not, but GI intolerance, diarrhea, that is always a major crippling factor for these patients. And pirfenidone, personally, I haven't noticed any photosensitivity in our patients. Perhaps the skin doesn't allow that, or maybe, but in general, pirfenidone is tolerated better. One adverse I have noticed is weight loss in these patients.
True.
Losing weight for no other reason, and we go on investigating for all kinds of metabolic disorders, nothing is found, but they lose substantially 8 or 10 kg. So these are the risk benefit ratios, because the benefit is something which cannot be left, and that is the only option that we have. So Dr. Jindal, how do you tackle these patients who are having side effects?
So I think with nintedanib, one advantage that we have is that between 150 and 100 milligrams, the loss of activity of the drug is not much. So with patients who develop purely gastrointestinal symptoms of diarrhea, I think switching, giving them a rest period and then coming back at 100 milligram instead of 150 actually works in a lot of patients. Yes. And of course, that is something that we don't see with pirfenidone, because unless you're giving a dose of 800 milligrams, it's just giving a candy to the patient, unless the patient is too low BMI, as Neel had also mentioned here. Yes, I agree totally with you that a problem of weight loss is there, but then are we ready to attribute that purely to the drug is the question that I have. Because the disease that these patients also have is a very highly catabolic disease. Absolutely. They have all the chemokines in the body which are taking away the muscle mass, which are taking away the bone mass. And along with that, the increased work of breathing that they have, that is just, taking away all the nutritional balance or whatever, energy expenditure they have in their body. So looking at a combination of those features, I don't think we can blame just the drugs. These are the drugs which are causing the weight loss. But yes, definitely with nintedanib, a tad bit better shade over there, because we have the ability to go down to a lower dose and come back at that.
Yeah, so but these are the problem, and hopefully the next generation of antifibrotics, they might address this problem of adverse effects. So we have to wait. But till that happens, these are only 2 drugs, effective drugs, no doubt.
Absolutely.
And we have to explain, and that I think communication with patients is very, very important. So I think now we move on to the other group of fibrosing ILDs, that is the non-IPF fibrosing ILDs, which some of these behave like progressive pulmonary fibrosis. So, Dr. Arjun, in your practice, like you would be seeing sarcoidosis, hyperpneumonitis, NSIP, connected to ILDs. So, how common is the fibrosing phenotype among each of these that you are seeing? Lots of fibrosis.
As you rightly said, all these drugs have all these diseases have the propensity to go on to progressive fibrosis. But what we most commonly see is hypersensitivity pneumonitis that is going on to what we call the fibrotic HP now, and sarcoid also going on to fibrosing sarcoid. And of course, NSIP, especially if the NCTD ILDs with the fibrotic NSIP pattern, patients also we see that they have a tendency to progress to progressive pulmonary fibrosis.
Yeah, actually, sarcoidosis is one of the exceptions. I would say that most of the patients do not go into fibrosis early. Only in advanced fibrosis, in advanced stage of sarcoidosis, we see that they have developed fibrosis of ILD kind of. Dr. Bansal, normally those patients who have fibrosis among the non-IPF, so what is the general approach to management that you are adopting?
First of all, yes, sir. First of all, we need to really look into whether they are progressing or not. We have to really differentiate whether this is only the fibrotic ILDs we are dealing with or the progressive fibrosing ILDs we are dealing with.
First time, when they come to you initially, you made a diagnosis. So at that time, the follow-up is not there, so you wouldn't know whether they are progressive or not.
Yes,
so
sir.
At that stage.
Yes, sir. So initially, when we are dealing with fibrotic ILDs, which are non-IPF, we should always try to look into the etiology, whether we are dealing with NSIP, HP, sarcoid, CTD, ILD, because initial treatment, that is immunosuppression, will depend upon the etiology. Like for NSIP, the first line of treatment would be like steroids. In HP and sarcoidosis also, but gradually, if the patient is not responding, in HP, we would like to emphasize on the avoidance of the antigen. In sarcoidosis, if the patient is not responding to steroids, then we would like to go on to the second line of drugs like methotrexate, azathioprine. So appropriate immunosuppression is the first keystone when we are dealing with non-IPF fibrosing ILDs, because there is little bit of inflammation always going on along with this fibrosis, which we should focus on, so that whatever is left, we do not, it's not progressing in nature, and we are able to halt that progression. Because NSIP, HP, sarcoidosis, these are the diseases which are which have a very good response to immunosuppression. If adequately treated, the dose is adequate, and the patient is compliant to the treatment before they progress on to the PPF etiology, PPF phenotype.
Thank you. So, Dr. Thakkar, these diseases like hyperpneumonitis or some of the connective tissue ILDs or sarcoidosis, these would progress in a subset of patients. Now, steroids, as Dr. Bansal has said, they are the cornerstone of treatment. Would there be patients where you would start with an additional immunosuppressant straight away, or you would wait for some response, adequate or not adequate, before deciding to add a second drug to these patients?
Sir, I just actually would like to differ on one point, what Dr. Bansal had answered, that when we are thinking of fibrotic ILDs, when you discussed, which is non-IPF, and suppose patient has come on presentation. So not all of those cases may not be the ones where we will consider steroids. If a patient has developed fibrosis already, which is advanced, and patient has come to us, in that case, the role of steroid, as per whatever literature and data available, would be limited to exacerbations when the patient presents. Besides that, where the fibrosis has not yet set in, where there is patient is like, we have the subset of progressive pulmonary fibrosis, where clinically the patient does not have, suppose has exertional desaturation, radiologically advanced changes of fibrosis have not set in, and in cases where we have, like, patient has not been, like sir has mentioned, that steroids definitely, where fibrosis has not set in completely in advanced stage, we should and would consider steroids. In cases with CTD ILDs, especially when patient is on steroids, has not developed advanced fibrosis, and has significantly increased in the level of symptoms, grade of dyspnea, 6-minute walk test, the distance is getting reduced, as well as the amount of desaturation is getting increased.
a lot of fibrosis visible on the CT. And as you say, patient would have taken treatment elsewhere also. So evidently, if he has reached a stage of fibrosis, which is showing a bit of honeycombing or extensive fibrosis, so that has progressed from a previous stage. So retrospectively, one can say that the patient has progressed. But because the standards of care are not there, so the recent guidelines on sarcoidosis, they did not mention about starting antifibrotics. So that requirement of 1 year observation to show a decline is there. But coming to our own practice, like Dr. Bansal, how often would you feel tempted to add antifibrotics straight away when you see advanced fibrosis in a patient with, let's say, hypersensitive pneumonitis?
So upfront, I would not start straight away, but first I would like to see how much steroids, whether the patient has taken adequate dose of steroids or not, the compliance was good or not, for how long he or she has taken it, because the PPF only we diagnose when the cavity is there, that the patient should have taken adequate standard treatment. But if the patient has taken standard treatment and then he or she is progressing, then I would definitely add on to that.
Like Dr. Jindal said, patient may have taken treatment elsewhere from me. He has
But
taken treatment, now he has gone to you. So
whether we will check whether the dosing has been adequate or not, patient has been compliant and how long.
There is always a possibility that when you got the patient's records, previous PFTs are also there, and there is retrospective evidence the patient has progressed. You see honeycomb.
Then we might add.
The point is, the time that we have got with the patient is limited.
Sir, can I just ask?
I'm coming to Dr. Just responding to what Dr. Bansal has said. But yes, Dr. Iyer.
Sir, can I just ask a question to everyone, sir? Please, if I may just ask one question. Sir, because unfortunately in our country, sometimes, we just can't blindly follow what, the guidelines say, because the scenario sometimes is very different. I completely echo what Dr. Apar mentioned. We have seen patients of ILD who have received even ATT and then come to us after a 6-month compliant course. Some of them very funnily also say that they have improved. It's a psychological. But, I just want to ask, very common in clinical practice, the main question which we have is a patient presenting to us with a CT of established UIP pattern who is having significant exposure to pigeons, okay, which is the most common offending factor if you see HP. And then we are left scratching our heads whether this is UIP, is this IPF, is this chronic HP? In such a case, will you still upfront treat with antifibrotics, or will you mix antifibrotics with steroids, is what I wanted to ask.
That is what we are discussing. Patients who have reached an advanced stage and they have taken treatment elsewhere. So it becomes a mixture of treatment that they have received. So whether steroids still have a role, one thing is certain, if they fall into the classical definition of progressive pulmonary fibrosis, then going by the recent recommendation, antifibrotics are definitely in. If 2 out of the 3 features, the clinical deterioration, then physiological deterioration, and if previous records are there, that helps to establish that the patient has progressed from a better stage to this stage, and already a lot of time is lost. So if the antifibrotics are going to work, this is the time to start. So that is my practice. Dr. Thakkar, what would be your take on this?
So finish your question.
Advanced non-IPF fibrotic lung disease,
Yes.
which you have, let's say, started seeing only recently. So no previous experience with this follow-up.
Sure, sir. So in the case example which Dr. Kapil Iyer discussed right now, that your patient is having advanced UIP pattern, history of pigeon exposure. So basically, as per the ATS 2022 recommendations, number 1, we have to define if we have any old documents of 1 year, number 1. So clinical, radiological and lung function, FVC decline, DLCO decline and radiology. So that if we have 1 year proof, then we can define PPF. Role of antifibrotic is definitely there. If PPF is defined, steroid role is only during exacerbations. That is as per what data we have today. Number 2, we don't have old data and we have to decide. So in that case, I'm just saying based on literature. Number 2, suppose we have a case where we cannot apply only literature, we don't have 1 year data and patient has straight presented. So there is one thing which I tend to apply in practice, that is the gap index. Now, gap index is actually an older modality which is used specifically for IPF patients, but looking at implementing that in clinical practice, that gender, age and physiology. Gender male है, 55-60 के ऊपर का age है, and physiologically जो PFT है उसमें FVC, DLCO parameters are significantly reduced. Then in such cases, we again already know that this patient has a very poor course in the future. So in such cases, in selecting those particular cases where we don't have a 1 year follow-up for steroid, this is again something which is a tool for specifically IPF, but because of the prognostic implication, it may help us in determining that specific subset where steroids we might consider, considering the poor risk outcome for such populations.
So Dr. Arjun, what happens to the use of steroids in such cases? Very low doses or stop altogether?
So it depends on what sort of treatment the patient has been having, has got before. Had it been optimal, perhaps we'll now reduce the dose of steroids to a low dose and add an immunosuppressant, and then watch for next 3 to 6 months and see whether it's progressing, and then add an antifibrotic. On the other hand, if the patient's treatment previously has not been optimal, then I prefer to start on an optimal therapy and observe him for the next 3 to 6 months and then take it from there.
Because I think all of us are practically saying the same thing, that if the patient has had treatment elsewhere and records are not available, then perhaps it would be better for the sake of the patient to start antifibrotics if the features suggesting deterioration are there and the CT features of fibrosis are evident. Because if we delay antifibrotics further, although standard guidelines do not still advise that unless, but that is the Western recommendation, that you have to have a 1 year period of follow-up, which is not there in our case. So I think clinical judgment is what we have to go by. And if the patient has progressed, suppose a patient like Dr. Thakkar says, X-ray, CT scan resembling UIP, now that is an advanced stage and patient has evidently progressed from a lesser disease to this stage. So that is by definition already progressive pulmonary fibrosis, isn't it? No. So I think the other aspect would be whether to continue steroids and immunosuppressants, because they may not be of much use at this stage. Dr. Jindal, 3 drugs or only antifibrotics then?
Now this is the real gray area that we have hit. So
yeah, that is why, because there are no standard of care. So that's why we are taking everybody's opinion on this. Yeah.
So what I would do is, if this is the first encounter, yes, I would start with all the 3 drugs. The antifibrotics will be there, the immune suppressant will be there, and of course a low dose steroid at this point of time. I don't think there is a benefit unless the CT scan is majorly showing ground glass opacities, where again the use of antifibrotics comes into the question. But yes, start with all 3, follow up the patient, and then my idea would be to take off in the manner of the steroid first, then the immune suppressant if it is not working, and continue only with the antifibrotics if we are slowly seeing a progression of the fibrosis and loss of the FEC, loss of DLCO continuously. If there is a definite improvement, I would just taper and maybe try to stop the steroids and continue with the immune suppressants, and the antifibrotic remains as the standard of care over there.
Yeah. These diseases like sarcoidosis or HP, because we don't know the inciting agent. So some bit of inflammation is an ongoing process. So my approach is that at least continue with a low dose of steroid, monitor for adverse effects, but taking them completely off steroids may not be an option in patients, because at least whatever inflammation is contributing to further fibrosis, we can attempt to alter that. So that would be my difference from managing an IPF with a progressive fibrosing non-IPF ILD, that immunosuppressant and steroids in low dose, because they are not going to be very effective, but we don't want to have adverse effects also. But whatever little inflammation is persisting, because there is no other way of making out how much inflammation is there now. Only we believe that sarcoidosis or HP have an ongoing inflammation. So I believe a bit of steroids, low dose steroids may still be in order. Dr. Arjun, any idea, any comment on this?
No, sir, I completely agree with what you said, sir, because that is what we follow and we need to do.
Dr. Thakkar?
Yes, sir. Steroids, specifically, like I said, in advanced fibrosis, in exacerbations, definite role. 6-minute walk test is something again which helps in determining a very significant desaturation is there. Again, that might be more responsive with the steroids when we give them. But I agree with your approach.
So this brings a clear distinction between managing advanced IPF and managing non-IPF progressive ILDs. That they still, we believe that there is a role for low-dose steroids and immunosuppressants, in addition to depending more and more on antifibrotics as we go along. So Dr. Jindal, ultimately, these patients will also reach you once we have added antifibrotics. So what would be the right time that you advise that we have got given enough trial to antifibrotics and now is the time to consider a transplant?
If you look at the guidelines and if you look at the recommendations, the ideal time to send the patient to a transplant unit, and now I'm not saying to transplant the patient, but to send the patient to a transplant unit is at the time of identifying a fibrotic.
Principle is same as in IPF. Now we are talking of non-IPF. So that is
the same. So the guideline which is made is for a fibrotic ILD. They have not differentiated between a not IPF and a non-IPF. So once you have an ILD which has gone into a fibrotic nature, you start talking to the patient about being inducted into the transplant program. And then you go in further for the investigations. So if the FVC has fallen below 80%, if there is a continuous fall in the FVC, if there is a continuous fall in the DLCO, say the DLCO has gone below 40% and now it is falling by 10% every 6 months, or the FVC is falling by 10% every 6 months, or if there is any appearance of the need of oxygen. So these are the parameters where definitely the patient should be inducted into the transplant program. We also follow the patient from that point onwards and wait till, yes, there is a further fall in the same numbers, the symptoms are progressively worsening, or now there is an appearance of complications like pulmonary hypertension. And this is the time when we actively look for a donor and transplant the patient. So this in-between time period is the period where we bank on the antifibrotics to work, keep the patient stable for a little bit longer, make sure that the patient is not having an exacerbation. And this is the time when we are looking for a donor for the patient.
So Dr. Iyer, since you have recently started assessing these patients, if a patient of non-IPF or even IPF with advanced lung disease, not a diabetic, no other comorbidity, so when it would be too late to consider transplant?
So transplant, basically, it's a huge emotional roller coaster, it's a huge physical toll. So basically, as Apar mentioned, in our country, if you just copy paste the ISHLT guidelines, it won't work, because we have to see very practically. All of us see patients who are referred to us quite late, who come to a chest physician quite late. Obviously, if we see our own practice, the first time a patient of any ILD is coming to us, the FVC is going to be less than 80%. Right. So Apar and me are extremely happy, because by definition, all of these patients have to come. So, unfortunately, we have to see. Now, when a patient becomes so progressive in which his oxygen requirement is off the charts, we don't have any cutoff. Number two, if he's got extreme comorbidities, which will obviously hamper transplant, for example, if anything is affecting his renal function in which his eGFR is less than 40, or if his ejection fraction becomes less than 45, or if he's got any other end organ damage, is when we have to completely be critical. Third, whenever we see that his pulmonary hypertension has reached the severe category, is one more thing that we are extremely scared of, because practically we have seen so many patients, the requirement of ECMO in these patients post-op can range from a week to even 3 weeks. And fourth, one thing which we are very certain about is we want the patient to have some amount of mobility and some rehabilitation potential, because if we take a patient who's completely bedbound, absolutely unable to move, and do a transplant, it just naturally translates into an extremely poor outcome. So these are the criteria in which we should ensure that the patient does not reach to such an extent, because then you might rather not do the transplant and just make sure that he has got whatever quality of life left in him.
I would also like to add one point, like in other non-IPF ILDs like CTD or sarcoidosis, we should always look for any extra pulmonary involvement. Like if there is any severe neurosarcoidosis or any other severe liver or heart involvement, then you should always look for whether you really want to go for the lung transplant or not, or whether you would like to go for.
Yeah, any extrapulmonary involvement adds to contraindications for these patients.
Yes, so that we should always look into.
Before I go to audience, Dr. Jindal, just one final question: is always a double lung transplant for these patients?
No, sir. That is something that is very individualistically decided. So an older patient who's more frail, the frailty score is more, the muscle mass is not there, I may just want to go ahead and do a single lung transplant there as well. So it's not a dictum that a double lung transplant has to be done. There is enough data earlier on until the 2014, 2015, the data which was coming in showed that there is a more survival benefit when you do a double lung transplant. But in 2016, 17, 18, there are multiple studies across Europe and across North America which has shown that the single lung transplant, especially for an ILD or a COPD, is also not inferior to a double lung transplant.
My concern is that these diseases which we relate possibly to environmental exposures, IPF is different, COPD is different, patient is given up smoking, but a patient of hypertension pneumonitis, if he is going to be exposed to environment, the donor lung would also be exposed, and if he has a tendency to develop, because this is a theoretical issue.
True. So if I talk about the observed data, so the recurrence of the disease in the transplanted lung, it is not up to that mark. We are not talking about 50% or 60% of the patients who are showing recurrence. A very small number, about 8 to 14% of the patients have a recurrence of the disease, and these are the patients who would come in again for a retransplant. It is mainly when we are dealing with things like bronchiectasis, cystic fibrosis, or non-cystic fibrosis, or suppurative diseases. These are the ones where, yes, double lung transplant is a dictum, because the infection from one lung is going to, destroy the transplanted lung. There, we have no choice but to do a double lung transplant. But for all the other indications, and then again, for pulmonary hypertension, yes, you would go for a double lung transplant. But for ILD, for COPD, a single lung transplant is also an option. The good thing in our country and the bad thing in our country is that doing a double lung transplant is easier, since there is no policy of allocating two lungs from the same donor to two different recipients.
Okay,
the set is allocated by the government for the same patient. Whether you use one lung or whether you use two lungs depend upon what you have registered the patient previously for. So we cannot use two lungs for two patients. Until the time we come to that and we start using more of organ donation as to fulfill the huge lists that we are accumulating now, then yes, single lung transplant would more often be required. And then just to make a comment onto a question that when is it a time to say that no to transplant in our country, as Kapil has said, that we most often see the patients late. He must also now, facing that the 70% of the calls that we get from doctors are when the patient is on the ventilator or when the patient is requiring an ECMO. And this is the time when, the patients and the families, they approach us. So if we start looking at guidelines at that point of time, then, a program which is already, I wouldn't say nascent, but adolescent stages in our country, it's been about 4 or 5 years that transplant has become more active in our country, and we start refusing all patients. It's not going to help the science. I don't think just because of what the condition the patient is in, we should refuse a transplant at that point of time. But yes, if it is beyond a single organ failure, then definitely, if there are other absolute contraindications, if there's a malignancy, if there's a psychiatric component, if the patient is retarded, then obviously I'm not going to transplant the patient. But just because the patient is very sick or very frail does not mean that we should refuse them right upfront. We should at least give them a chance, give them a counseling, try to induct them into rehab. Or if it is an ECMO transplant, you have to make sure that the family understands that we are not talking about a 90% survival benefit, but we are talking about a 25% chance of survival benefit over here. And if they're ready, we have to offer the choice to them. So let's not take the choice away from the patient and family and make it for them.
So one quick round.
Sir, if I may just add one point, sir, in this, the major difference.
Very brief. Yeah.
The major, factor which will decide between double and a single lung is actually pulmonary hypertension. Because we see ILDs and COPDs, and when we have to decide about pulmonary hypertension, a right heart cath, a single lung transplant versus double lung transplant, a right heart cath, which will show us the presence of pulmonary hypertension, is often the deciding factor. Any amount of pulmonary hypertension and you put in a single lung, you are just asking for trouble, because post-operatively this patient will go into massive right ventricular dysfunction. You will have to put a right ventricular assist device and all of that, and it's just absolutely horrible. Right ventricle often is very underestimated, in the entire transplant community. So this is one factor which we at the baseline we see. So any amount of pulmonary hypertension, it's better that you go in for a double versus a single.
Okay, so now one quick round related to COVID. Just one question, starting with Dr. Bansal. Dr. Bansal, you think COVID can be classified as a progressive pulmonary fibrosis or not?
Completely not, sir. To my experience, all the COVID fibrosis, they have been reversible. Only 10 to 15% of the residual fibrosis may remain who were seriously ill, like who were requiring NIV or HFNC, right? But most of it, more than 90%, it was reversible. I would not label it.
Not a progressive pulmonary fibrosis. Dr. Arjun?
I do agree, sir. Less than 5 to 10% of people have a persistent fibrosis. Most of them reverse.
Not persistent, progressive pulmonary fibrosis.
No, they don't even have progressive pulmonary fibrosis. Whatever fibrosis that remains like that without causing much of a harm. So I will not classify it as.
Only a one-time damage and never progressive. Dr. Thakkar?
Sir, I won't classify them as, most of them, like already mentioned, there would be some degree of reversibility over a period of time. But there is a double hit hypothesis. So if a patient has a tendency towards fibrosis, suppose like we are discussing progressive pulmonary fibrosis patients in an early stage. Such patients get a severe bout of COVID pneumonia.
So that is different.
They're a double hit. That will progress faster.
Primarily because of COVID.
Yes. There is that immune hit is there when the patient has a severe COVID pneumonia on the background of an early interstitial lung disease which has not gone into fibrotic phase. But
that is different. In a healthy lung, if COVID occurs, that is not because the 2022 document that doesn't mention COVID as a cause of progressive pulmonary fibrosis.
Not as a cause, just as an accelerant. If it is,
because COVID hit was just a one-time hit, and it led to a lot of damage. And at that time, Dr. Jindal would have seen lots of patients who were transplanted. But then that is over, isn't it? Now they're patients with 2 years previous exposure, they are not coming with advanced fibrosis.
Absolutely. I think majorly what we saw was an interstitial lung injury in these patients, which is not translated into an interstitial lung disease. A very small percentage of them, as Shweta mentioned, maybe less than 10% of them are those who have got residual fibrosis also now. And over a period of time, we saw many of these cases, which earlier on we classified as an ILD, showed resolution of their fibrosis, which was something very astonishing. So, actually, that begs the question whether it was at all fibrosis or a fibrosis like change on the CT scan that we saw.
Maybe picture did suggest fibrosis, but possibly it was just thickening because of inflammatory injury, and that got.
So I would not classify that as a progressive pulmonary fibrosis.
I'll quickly go on to some audience questions before we finish our time. So there is one question, Dr. Arjun, will start with you. Pirfenidone 801 milligram TDS is enough or higher dose in antifibrotics?
So this is the recommended dose, but we find that even our patients find it difficult to have such a large dose of the drug. So maximum we go is 2,400 milligram per day. That is 800.
Dr. Thakkar, just COVID related, post-COVID fibrosis, should pirfenidone be given?
No, sir. Again, like I said, not plain post-COVID, it should not be given. Absent in presence of underlying ILD with COVID later on, based on the clinical CT and lung function and 6-minute desaturation, we can then decide.
Because COVID was one time where, we didn't have any evidence. It was an emergency situation and people did use a lot of antifibrotics. Even drug trials were...
We didn't have that much data also.
But now that we have had 2 years experience, now we can surely say that antifibrotics are not indicated either immediately during COVID or thereafter.
Definitely.
Right. Then how to combat the GI effects of nintedanib and pirfenidone that we have discussed already. Then GI effects again. Dr. Thakkar, in new CT-ILD cases, how will we taper steroids and how long we need to continue? Let me reframe this question. Would steroids be given in all patients with CTD-ILDs?
Sir, again, it would be, we have to decide based on the patient's condition when we diagnose what, suppose the patient has got significant ground glassing.
Especially etiology-wise, if I can add in a bit more, PSS and RA, let us say.
Rheumatoid arthritis and
PSS.
Sir, in those particular cases, again, number one, we go on the history, the level of symptoms and the level of desaturation on exertion. Based after that, the lung function and the radiology. If there is significant ground glassing compared to advanced fibrosis, there is early appearance of fine reticulation, which is just starting off. And in cases where we definitely have an etiology like rheumatoid arthritis there, so the steroids are going to help for the lung also and for the primary etiology also. So in such case, definitely it would help. And in such case, because of the primary etiology, we might be using other immunosuppressants also. The question mentioned regarding how long and how do we taper off. So whenever we start off, we have to look at the patient's body weight, overall clinical profile. Suppose a patient, we also have to look at the comorbidities. If they are very uncontrolled diabetic, we also have to make sure that with the steroid use, we optimally, the sugar is also controlled for the patient. And based on that overall parameter, based on the patient of level of symptoms, the lung function test and radiology, and overall clinical progress over a period of 3 to 6 months to 1 year, we decide based on the clinical assessment regularly as to what maintenance dose the patient needs and when we need to increase that during the particular subset of exacerbation. For such cases, we need to continue them for a longer period of time, at least till the patient has not developed advanced fibrosis when they would not have a significant role.
This question is related to liver plant actually. And Dr. Jindal, can nintedanib be used in liver transplant patients with PPF?
I think it's
liver transplant with PPF.
Area question. We need to remember that the patient has had a liver transplant already. It's a precious organ, but it's a normal functioning organ. So if the liver functions are good and we are continuously monitoring the liver function, we have to be on our toes that, we don't let the transaminitis exceed at least 3 times more than the normal. We have to intervene early. Then there is no harm in using nintedanib for these patients.
In earlier trials of nintedanib, there was an issue with intestinal perforation mentioned as a very rare side effect. The recommendations advise caution in patients with perforation history. So what is that caution? How do we tell the patient? Use it or not use it?
So I think the safest way is to not use it. If you have a patient that has had that history, better not to use over there.
What about acute MI history?
Sir, here, I think the crowd is divided for that. There are many pulmonologists who would continue to use nintedanib in patients who've had a history of acute MI also. It depends. If the patient is able to tolerate full doses of pirfenidone, and we have to achieve a dose of 800 milligrams. If we are not achieving that, then we are not doing our job. If the patient is able to achieve that, I would prefer to use pirfenidone in those cases. Otherwise, yes, why not nintedanib? We have to weigh and balance both the situations. We know that the history for MI is there, and that is also under medical management. We can't let the lung condition get out of hand in that case. So definitely drug therapy would be advisable.
Dr. Bansal, what about steroid myopathy? Any experience how we would manage steroid myopathy? This is one of the audience questions.
Yeah, steroid myopathy, sir. The thing is, we need to really look into whether we really want to steroid. We can taper off the steroid to the minimal dosing or not. And obviously, the muscle training, etc., and looking into the other nutritional deficiencies, protein deficiencies, and other vitamin deficiencies, we should look into which can be contributory to the myopathies, not only the steroid which are contributing.
Yeah, because it becomes an issue of whether it's necessary to continue steroids or not, whether steroids are having beneficial effect or not.
We can taper down to the minimum.
Myopathy and osteoporosis are practically, you can't escape these adverse effects. One of the ways out is to possibly try.
Differentiate also.
an alternate therapy or lower dose, but within steroids, there is not much difference. That is my experience, whether you use methylprednisolone or prednisolone. Dr. Thakkar, what about deflazacort? Because this question has been raised. It's a steroid, but is it a steroid with steroid effects or just a drug with no effect? Because if you search PubMed, you don't find many articles on deflazacort.
Sir, again, it is by function, by action, it is definitely a steroid, but potency-wise, whatever available trials, European, American, Asian, whatever trials we have not been done on deflazacort. But again, just because we don't have it should not be that, okay, we cannot use deflazacort. We can use it with equal potency, with parallel, as per the dosing, with prednisolone. That if we are using as per the patient's particular weight, equipotent doses with prednisolone, there is no theoretic contraindication. But again, as per whatever literature, whatever trials available, we don't have too much data on that particular molecule.
So what would you consider equivalence, weight for weight, deflazacort and prednisolone?
Sir, again, like 100 milligram of hydrocortisone is
deflazacort.
No. Okay, so 20 milligram of prednisolone would be equivalent to somewhere around 4 to 8 milligram of deflazacort. That would be the rough equivalence.
Okay.
So it would be 4, 5, 6. 4 milligram of methyl is 5 milligram of prednisolone and 6 milligram of deflazacort.
Yes. Yeah, 20 milligram will be equivalent to 24. Yeah.
I don't know. Our experiences may differ because very often I have had to switch patients back to prednisolone from deflazacort. Or Jindal,
the only advantage that we saw with deflazacort was a better glycemic profile in these patients. So patients who had very severe diabetes and uncontrolled diabetes and did not require high doses of steroids, I think that is the only profile where I would prescribe deflazacort. It's again, as you said, there's not enough data. It's an opinion-based question. So I would not switch. I mean, I would not go to deflazacort in somebody who's not a diabetic, or who's a diabetic who's well controlled with OHS, not on high doses of insulin. Definitely, potency-wise, it's a poor steroid. So rather than using a poor steroid in high doses, I would use a more potent steroid in lower doses.
I agree, because what I do is I tell my patient that using steroids is more, you need steroid effect more than anything else. Diabetes, if need be, switch over to insulin for a better control, because we can't lose the effect of steroids just because of a possible risk of adverse effects.
And nowadays, with the appearance of these drugs like semaglutide, the oral SGLT2 inhibitors and all those things, I think glycemic control is way ahead of what we saw it 20 years back.
Options are there. Are a few questions in which I think I'll again request our panelists for opinion one by one. Combined use of pirfenidone and nintedanib. There are some studies also published on adverse effects, although they would have collected data on efficacy also, but that has not been reported in literature to my knowledge. Dr. Bansal, any role for combination of pirfenidone and nintedanib?
So in IPF, there has been few studies which have shown that there might be added effect, but not.
What they have shown is that the adverse effects don't add up. They haven't talked about additional benefit effects. Synergism.
Yes, sir. So studies are in IPF, not in progressive pulmonary fibrosis.
So when would you use, or when would you be tempted to use a combination?
So I have never used it.
And any reason to use a combination? Dr. Thakkar, any reason to use a combination?
Reason to use, more importantly, reason to not use. Like whenever we are giving a patient any treatment, it is all the dictum is always primum non nocere. So whatever we try to treat, we first have to make sure that we are not adding harm. So at the same time, suppose we are thinking a patient is not improving on Perfenix, then we focus on the rehab parameters, oxygen, the control of comorbidities, rehabilitation parameters. And still, despite that, if it is not, the patient's condition is not improving, then what benefit we might do with adding the antifibrotic, more help we can do with calling up Dr. Apar Jindal or Dr. Kapil Iyer.
Or switch over to nintedanib. Really, Dr. Arjun, ever had this temptation to add nintedanib to a patient who's failing on pirfenidone? Or you stop pirfenidone and switch to nintedanib?
No, sir. No temptation to add on and stop on and move on to the other.
But what I have felt is that if you have lost enough time on pirfenidone, then wasting another year on nintedanib for a possible effect would be wasting too much time. And Dr. Jindal would be the right person, or Dr. Iyer now, to send these patients rather than try pirfenidone for 1 year, then nintedanib for another year, and lose 2 precious years for these patients.
So the worst thing that we have seen, and I've seen many patients who've come to me who've been on combination of pirfenidone and nintedanib and then referred for transplant, is half dose of pirfenidone and half dose of nintedanib. So you're not giving the actual therapeutic effect of any of these drugs to your patients.
Exactly. So one has to use fully and try to give the maximum benefit, because it's very important to know whether your drugs are acting or not. So when to start them and when to stop them, that is also very important. That I think applies to all the 3 classes: steroids, immunosuppressants, and antifibrotics, because pushing drugs beyond their limits again is not going to help the patient and lose precious time for the only possible option, surgical option that we have for these patients. And although that, as Dr. Jindal said, that these patients may be coming to you little later now because of antifibrotics, ultimately the drug doesn't reverse the basic pathology. It only slows down. And the rate of decline is still more than the normal rate of decline. Even on antifibrotics, a person loses about 90 to 100 ml per year, which is more than 30 ml in a normal person. So ultimately, the patient is going to reach a stage where surgical option would be required. So I'm glad that we have more centers, and Dr. Kapil is another budding transplant pulmonologist, another center in Ahmedabad. We have got more centers in Delhi also.
Actually, I'm also, sir, presently in Vienna, Austria. I'm getting the training for the transplant pulmonology here for 1 month.
So that's wonderful. So very soon we'll have a society for transplant pulmonologists in India.
There is a society, sir. There is a Indian National Society for Heart and Lung Transplant. And actually this October, we are conducting the national conference also here in Chennai.
So it has been a wonderful discussion. We have covered all aspects of idiopathic pulmonary fibrosis, then non-IPF pulmonary fibrosis and progressive pulmonary fibrosis, medical aspects, surgical aspects, use of antifibrotics. So great learning experience from all of you. Dr. Thakkar wants to say, I'll just come of one final round to everyone. So starting with you, Dr. Bansal, final message after today's discussion.
Sir, my thing would be like before diagnosing any diseases, primary pulmonary fibrosis, like progressive pulmonary fibrosis other than IPF, you should always try to see whether the patient is already on proper medicines or not, and only then you should be able to add antifibrotics to them. And proper follow-up is very, very important, and you really have to be patient for at least 6 to 12 months for the response to happen.
Dr. Thakkar, you wanted to say something?
Sir, again, just one point which I wanted to raise was there was a question regarding CTD-ILD and transplant. I just seen that question. So besides that, and to as a message that, so we have Dr. Apar Jindal sir and Dr. Kapil Iyer sir with us today. So what I had like CTD-ILD, we would normally have a lot of hesitation. Like Dr. Bansal had also discussed earlier that koi patient if has an extrapulmonary symptom or extrapulmonary involvement, we would be like, there is a theoretic hesitation that, okay, this patient may have a risk of relapse later even on the transplanted lung. But there is that theoretic risk. But like Dr. Apar Jindal had discussed earlier, that does not nullify the category of referring for transplant. Why
Exactly.
is
It's not
that
a contraindication. Yeah.
5 years down the line, I have, like with a case which Dr. Jindal had seen, it's been 5 years already. That's not data. That's a patient I have who had a CTD-ILD and is still doing well post-transplant. So that is something which is definitely that on appropriate immunosuppressant and appropriate therapy. But we should definitely not be very conservative when we think about that modality in today's time. With obviously the mainstay will remain managing the patient, rehabilitation, antifibrotics, oxygen. Again, one of the most important for oxygen and pH therapy would also be there. But referring for transplant would also be now in our armatorium, even with some degree of extra. I'm not saying all cases, but in selective cases.
And these patients would continue to require specific treatment for their continuous disease in any case, even after transplant. Right? Dr. Arjun, last few comments, message?
Thank you, sir. I understand that there are more than 1,000 logins for today's program, 1,044, I think that's what I understand. So what I'd like the audience to take home is that when we deal with patients with non-IPF cases, we should always have high index of suspicion that they might progress to progressive pulmonary fibrosis. So we should be always on the alert, on the lookout for symptoms, the physiological changes and the CT changes, so that we can pick these patients early and start them on appropriate antifibrotics.
Yeah. Proper and systematic monitoring is necessary. 3 to 6 monthly PFTs, at least one annual CT scan earlier if indicated, plus the monitoring of their pulmonary circulation. That is very important, how the pulmonary hypertension is developing. So Dr. Jindal.
So I think very good gist that has come out from the decision is a paradigm change in our thought process. We are not splitting hairs again. We are lumping the disease. So we are looking at fibrotic ILDs and progressive fibrotic ILDs so that we can easily streamline the therapy for the patient and easily monitor these patients to give them the maximum benefit. And of course, being in the field that I am, the benefit has to be offered to them in a very timely manner rather than when it's too late.
Yeah, so these studies have been very useful. At least they give you one more option to add to patients who have got fibrosis apart from just trying to suppress their inflammation. So finally, Dr. Iyer.
Sir, I've just got one statement and I'm quoting the ISHLT guidelines. The first point which mentions the referral criteria is if you've got a patient with fibrosing ILD having an FVC of less than 80%. So I want every single person who's logged in, listening to this, that this should be the take-home message. And while we argue about porphyrinol, nintedanib, steroids, and azathioprine, please do not forget to refer to a transplant pulmonologist.
We'll have this as another debate sometime because 80%.
We are okay with the debate, so we can have that debate.
Conversation will become very difficult.
All the patients.
I think I'll request Dr. Krishna to have another webinar on when to refer patient for lung transplant. We'll sort this out issue later. So we are running out of time. So thank you, panelists. I would like to thank Dr. Arjun, Dr. Bansal, Dr. Thakkar, Dr. Jindal, and Dr. Kapil. Thank you. With your mask on, you have been coming in and out and giving valuable comments. So wonderful evening, great discussion, and I am sure everybody has enjoyed this discussion. And as usual, this will be available on YouTube, and I look forward to another round of discussion because the way things are changing, new information will come. Next year, we'll have some more issues to discuss. So till then, goodbye, everyone. Thank you very much. Good night.
Thank you. Thank you, sir. Good night.
Good night.